Welcome to VIVA Unscripted, an ongoing dialogue that we have to sort of look at the data behind the data and the reactions to that data. And this is sort of a free-form interactive type of forum that we have here. I'm happy to have with me Dr. Rabih Chaer over to the right, Dr. Bob Schainfeld a little bit closer to me. So guys, we just saw some pretty exciting presentations in late-breaking clinical trials, and probably more than we can cover in the time we have available. But why don't we start with the very first thing, which is Lutonix below-the-knee trial. So Rabih, let me just ask you, I mean, the plain old balloon arm, as seen in Impact Deep, did very well, 60% or so, primary patency at 1 year, which was improved upon with the DCB with the 10% or so delta. Is this compelling enough for you to change practice? And what would you really need to see to sort of change to DCB routinely?
I think it certainly addresses an unmet need, but what we saw this morning is definitely very promising, but we need a little more information that he was able to present to us. It was interesting to see the endpoint that they chose, which is really a composite endpoint, and maybe looking at, and you did ask that question, what was the driver of the endpoint, the primary endpoint, but maybe, what was the primary patency? What was the wound healing? Amputation-free survival is not a very sensitive endpoint from what we know from all the trials, but certainly very promising and hoping to see a little more detail about the other endpoints that I'm sure they have.
Right. It was interesting, Bob, they focused very much on the safety endpoint, which is important, right? We knew from Impact Deep that there was a signal towards impaired wound healing. Do you think the safety endpoint is sufficient? Really, what do you want to see before this becomes your practice?
Yeah, I think I've been doing this for a couple of years, and we were part of some early angiogenesis work back in the early mid-90s. And the reality is patency, primary patency, assisted, secondary, really in the tibial vessels doesn't mean very much to me. It really has to be a clinical endpoint. Ischemic rest pain, obviation and or resolution, lower amputation rates and or lower level of amputation rates, wound healing, trends toward wound healing. I think it has to be hardcore clinical results and or endpoints more so than hemodynamic and or patency. And I think tibial vessels behave very differently than anything else. I think medial calcification is really the player in it, and therefore the pathophysiology is very different than SFAs and some of the other vascular venues that we intervene upon.
So just stay with this one for another moment. I mean, how applicable do you think this is to the patients we actually treat? I mean, if you look at it, 15% had severe calcification. They only were able to apply or randomize the technology in patients who did not have flow-limiting dissections after predilation. So it's not representing everybody. So do you think this is really data that's applicable to 1 in 10, 1 in 5, or 1 in 2 patients that you treat?
It's a good step, I think, but certainly we see more extensive disease, and yeah, I mean, it is expected that they would cherry pick the patients like that, but I would say maybe 30%, it's just a guess, applicability for real world anatomy and patients.
So Bob, there's a lot of technologies out there for below the knee. Obviously there's trials now with scaffolds. The bioabsorbable has gone away, but there's at least 2 trials, one with a drug-eluting scaffold, one which is a sort of a woven nitinol stent below the knee. Obviously there's Intact. There's other technologies, laser and drug delivery. You had to put your dime down. Here we are in Vegas. Here we are gambling. What are you going to be betting on?
Maybe I was influenced about a decade ago with a gentleman, Graziani, in northern Italy. And the Europeans, to what it's worth, whether it's economics driven or not, just a real meticulous, detailed balloon angioplasty, and I think it goes back to the mechanism of medial calcification in the tibial vessels. It just behaves differently than other beds. And I think a long, prolonged, extended balloon angioplasty, decent looking result, get out of Dodge, see where you play out clinically, and perhaps secondary and or tertiary is primary assisted patency and or driven by what your endpoint is, wound healing. Maybe that's what I would probably use as first line of therapy unless you really got in trouble. But contingent all these other technologies, atherectomies and balloons, or stents and or drug-coated balloons and the like. And maybe I've just been around either too long and or become a little bit of a curmudgeon in that field. But I think a meticulous balloon angioplasty, good angiosome, perhaps guided and as comprehensive an intervention as one can do, maybe that's really I put my dime.
Yeah, I've known you a long time. You're not a curmudgeon, so I agree with that. So, Rabih, just, with all these technologies, whether it be Lutonix or something else, what's the cost barrier impact on, the adoption of these therapies? I mean, it could be this, or it could be tax, or it could be something else. We know there was no incremental reimbursement approved this year in the U.S. for DCB. How does this play into the decision making?
It might play into the decision making, although in the SFA and popliteal, we haven't really, at least in our practice, seen it to be much of a deterrent in terms of the adoption of the technology. Yes, it's not as lucrative for a hospital system, certainly not for outpatient labs, but I think if it pans out to be beneficial in terms of outcomes for patients with CLI, I think it will still be adopted by practitioners if it does truly make a difference.
You think this data is compelling enough to lead to incremental reimbursement?
Well, not yet, I don't think.
Right. Okay.
It was way more compelling, I think, in the SFA and POP from what we know so far.
Sure.
And yet this did not
More
last too long.
transformative, right?
I'd agree with that too. I think that's an important point, absolutely.
Yeah.
Apples and oranges.
So, not in the order of the late-breaking trials, but sort of staying kind of on topic in the first in the arterial realm, the data presented by Ken DeLuce on the VMA trial on common femoral is really very provocative, right? And Ken's been leading the way for many years and a friend of VIVA for a long time. Are you currently practicing common femoral artery endovascular interventions?
So I'm a vascular surgeon and I do practice it, but selectively so.
Right.
The teaching for vascular surgeons is that the profunda is the left main for cardiologists, so you don't want to really mess with that. So I do not really overstent over the profunda, but I have certainly ballooned, sometimes even used DCBs, sometimes stented the common femoral, selectively so for high-risk patients, either because they have medical comorbidities or because it's a redo groin. Any reason that I don't want to operate on them, I have done it, and it does work well, I have to say, but I do have concerns about messing with the profunda.
So I got to ask you this: what are you thinking? I mean, here you're a vascular surgeon. You have strong held, firm to the idea that the common femoral artery interventions are sacrosanct for surgery. I mean, what in your mind changed that led you to start considering an endovascular approach?
It's a risk benefit. I mean, if you have an inflow lesion right above the bypass and the third time redo groin, and you know that the technique works relatively well, why go back into that groin and run into more complications? I mean, there are a lot of patients who would do well with that technique just because the surgical approach, yes, works, but it has trade-offs in those high-risk patients.
So you're just being a rebel or a pioneer? What do you think?
I think I'm just being reasonable. If I were a rebel, I would be using it all over the place. I think what we saw earlier in that presentation is bordering on the rebel side because of the profunda overstenting. But I think a lot of vascular surgeons actually do that and do treat the common femoral endo in certain select patients.
So, Bob, you've been doing this a long time. This is a different approach. Teco is a different approach, putting stents in. Yesterday we saw a live case that Chris Metzger did, and obviously it was magical. He actually in that case went ahead and did lithoplasty. What do you think of the comparative merits of each of these technologies? When you sort of look at this, leaving something behind, long-term patency, avoiding compression and so forth and so on.
I attribute I call it the godfather, if you will, the profunda, and I've been teaching that mantra perhaps to their fellows for 1,001 years. But be it as it may, we have been doing common femoral angioplasties probably for 20 some odd years. We published some data in abstract form back at ACC about 95 or so. Not all common femoral disease is created equal, both morphologically, substrate-wise, and/or comorbid and longevity, patency, patient's chronology, and the like. I loathe the fact of preemptive stenting, perhaps in any vascular bed, but I think more so, a little bit more putative is the common femoral. And I think common femoral profunda SFA osteal disease is very different than isolated CFA disease, and again, the morphology is such. A 40, 50-year-old smoker versus an 80, 85-year-old CLI that just needs to get over the hump. I loathe to put anything in there unless it's really flow limiting and or restenosis times multiple. I like the idea of debulking, and I like the idea of perhaps as Chris did yesterday with the shockwave therapy. I'm intrigued with that, and I'm intrigued with the concept of debulking, optimizing angioplasty, call it a day, aggressive duplex, and real contingent, perhaps provincial use of stenting across the profunda femoris. It just does not feel kosher, but it's my personal.
So are we ready yet for another randomized trial to open surgery? And would you have a trial where you have multiple potential endovascular options?
The idealist and perhaps the trialist in me would be a wonderful idea. We just struggle like the dickens with all our peripheral trials for whatever reason, and some of which are very obvious. I think at the end of the day, perhaps that would be a laudable effort. In reality, I think anytime I touch a common femoral and I preach to the choir, I always, 100% of the time, have the endorsement and/or advocacy of the vascular surgeons up front. They'll review the films on the table before I instrument with a contingent plan, perhaps, of either something going awry or maybe this gentleman would be best served with a bovine patch and an endarterectomy. But I think you need to debulk /optimize the angioplasty alone before you stent, but that's my take.
Well, we switch gears a little bit and talk about the treatment of erectile dysfunction, vasculogenic erectile dysfunction. I'm not sure exactly what the workup was in those patients. I presume they had arterial Dopplers, with and without provocation, but it seemed to me a pretty intensive amount of interrogation and intervention. Is this something that sort of sounds appealing to you, or what do you see as the limitations in this approach? It's not for everybody.
True. I mean, I don't even know how many vascular technicians have done a penile brachial index to figure out whether it's hemodynamically significant or not. The classic teaching is that it doesn't work, but maybe it doesn't work because it's not as extensive as what they presented, the CPR approach. I don't really know whether it's a game changer what we saw today, and whether it will make a true impact or not. Clearly there's a need for more, because what we do now in terms of pharmacotherapy does not necessarily change, but maybe it's small vessel disease related to diabetes, and that you're not going to fix. So I don't know. I haven't done it. I have done it selectively in the internal iliac and large branches, but I have not chased it all the way down, and the success rate is anecdotal.
It's interesting. I mean, those are arteries that don't generally interrogate, but now with the growing interest in things like prostate artery embolization,
yes,
there are people who are sort of making their way down to these small arteries and very comfortable in this vascular anatomy. Maybe those are the individuals who will now sort of enroll in treating this. But my experience, and Bob, I'm curious if you share this experience, that we're asked to treat these people from time to time. We do formal vascular testing. We no longer do intracorporeal piperacin and phentolamine like we used to do, thank goodness. But when we get down there, generally it's very distal, small vessel disease. It's very hard to identify, the vessel in its continuity through the dorsal penile artery. There are hard lesions that course. There are hard lesions that dilate. Not quite so easy as it seemed there. Yeah. I mean, what's been your experience through the years, Bob?
Yeah, I got a disclaimer. I know nothing about impotism or erectile dysfunction, but be it as it may, I fell into it a couple years ago when somebody had some buttock claudication. They meticulously interrogated the ossea of the internal iliac hypogastric angioplasty on occasion, very rare. Be it as it may, I may have put a little balloon expandable stent in there. And oh, by the way, when he came back at 3 or 4 weeks, he offered up anecdotally, if you will, because I was not vigilant enough to query that piece. But on a routine basis, I think it's way more complicated than just simple plumbing. And indeed, it's just a comorbid substrate of diabetics with other reasons, etiologies of which this may or may not really be the player and or the contributor to the pathogenesis.
Interesting. Let's just quickly touch on the biosentry. This is an interesting idea that you implant this, it aligns, it doesn't cause any cable penetration, and has a 6-week prescribed time until it opens up. Game changer or fluff. I mean, are you comfortable putting a permanent implantable in somebody who's pending like hip replacement when they're not that old?
I guess the essential question remains as to who needs a filter, because we really overutilize filters in the U.S. and it is attractive to use in certain situations, but they had 16% of patients who had clot or failure of conversion, so that sort of becomes a permanent type of implant, which is semi-lumen obstructing, that can potentially, it didn't cause that in this trial, PEs. I don't know if it's a game changer, because I think the essential question remains as to who needs a filter and should we be more selective than we are now.
And I guess part of the question, Bob, I mean, is it more appealing to put in a device like this, which is a permanent implant, even if the central portion resorbs, or within 60 days to go ahead and remove a implantable or temporary filter and leave nothing behind? I mean, what's your philosophy about this?
Yeah, I mean, part of the query I had posed to Michael, to Dr. Dake, who were the subset, the cadre of patients that perhaps it's suitable for, and he appropriately sort of spun it, and who's it not appropriate for. I just have a bit of a reticence and apprehension about leaving a device in perhaps a young individual. I hope, perhaps a little bit overconfident that I know who needs a filter, perhaps who needs the filter retrieved, but I don't think the omission on the part of practitioners, colleagues, associates, whomever else, that we don't take filters out aggressively as we should in terms of surveillance should portend and/or substitute another technology. I think there's a small subset of folks that perhaps this may have applicability, but I can't imagine it's generalizable at all to the population that I see on a daily basis.
You're right.
It's just something inherently awry about maintaining a prosthesis in a young individual that perhaps would be best served with a virgin VIVA.
So, guys, before we close, 30-second questions. Rabih, what else do you like to do in Vegas besides come to VIVA? What's been part of your VIVA experience? Shows, restaurants, clubs? What's been fun for you?
The food scene is just amazing here, and all concentrated in one small area. So.
Right. Great. Any particular recommendations?
Well, we actually tried a Chinese restaurant here at the hotel, which apparently is the first Michelin-rated Chinese restaurant in the U.S., Wing Mei, and it was just
amazing thing.
Amazing. I mean, just different from the Chinese I knew.
Right,
just put it this way.
And Bob, I have to ask you this, but who's going to win the Super Bowl?
Unfortunately, it's not my Eagles this year. I think they had their Cinderella run, played way beyond their means. But that was true house money, and I wish I had bet the house on that sucker. I watched it with about 20 Patriot fans and a lone Eagle guy myself, but it's not their year. But
Rams, Patriots.
Nah, neither
Chiefs?
one of those two. Chiefs look pretty fair. Andy Reid's a pretty good coach. Cut his teeth on the Eagles.
All right. Anyway, thank you very much, guys.
Thank you, guys.
Really amazing data. Appreciate your time. Thank you for joining us here in VIVA Unscripted.